Okay, today we will finish lung cancer, inshallah, and start prostate cancer. طيب, فإحنا last time we talked about management of advanced disease, non-small cell lung cancer. We said that tumor histology is important because the treatment depends whether we have squamous disease or non-squamous disease. And we talked about the targeted therapy, like EGFR inhibitors, ALK rearrangement inhibitors, and we talked about angiogenesis inhibitors like bevacizumab. حكينا عن ال first line, second line treatments, وحكينا عن ال maintenance that sometimes we can consider in certain situations. generally speaking, المرضى اللي هم بيكونوا stages 1, 2, or 3A disease, usually, as we said, we give a platinum doublet. بالstage 1 مش دائما نعطي chemotherapy, okay, لكن يعني in general خلينا نقول in stage 2 disease, 3A disease, patients take 4 to 6 cycles of a specific or a selected platinum doublet, and we don't have routinely any maintenance treatment. فالمريض بيصير off therapy, لكن بيكون under monitoring, يعني in surveillance, okay. بالمرضى اللي بيجوا بالstage 4 disease أو 3B advanced disease, sometimes we might consider maintenance therapy, okay, sometimes not. وإذا ما صار maintenance therapy كمان هدول المرضى بيكونوا under surveillance, okay. التريتمنت approach بيعتمد إذا المريض بيقدر ياخد maintenance أو لا، بيعتمد على الهيستولوجي and so on. هلا other type of lung cancer, which is the small cell lung cancer, in general we said this is more aggressive lung cancer disease, and relapses, recurrence is very common. Even survival time is much shorter if we compare it with the non-small cell lung cancer. هلا the staging with small cell is different. We don't routinely adopt the TNM staging. The staging هون بيعتمد على where do we see the tumor mass, and does it involve a single lung or both lungs, okay? فبالتالي we divide small cell lung cancer into limited disease and extensive disease. Limited disease means that the tumor is confined into a one mass in one of the lungs, did not extensively يعني locate أو موجود in both lungs, فهذا بنقول له limited disease. هلا more diffuse tumors or tumors that found in both lungs هذا بيكون extensive disease, okay. هلا unfortunately most patients with small cell lung cancer at presentation they do have extensive disease. يعني نحكي إنه حوالي 70% من المرضى اللي عندهم small cell lung cancer بيكونوا already in extensive disease, okay, which means really a very aggressive form, okay. The survival chances are really low. فهي واحدة من المشاكل إنه عادة المريض بيجي ب really advanced or bad or aggressive presentation in the small cell lung cancer. هلا حكينا إنه بال small cell lung cancer usually surgery is not a cornerstone option. يعني in many cases the tumors are not resectable or operable. فبالتالي we rely mostly on radiotherapy, okay, definitely with chemotherapy. يعني chemotherapy is always there. لكن surgery is not always doable or rarely doable, okay. فبالتالي we consider radiotherapy especially in cases of the limited disease. يعني إذا المريض عنده limited small cell lung cancer. إذا في طلاب اعملوا mute please. إذا عنده limited disease small cell lung cancer, usually we do chemoradiotherapy, okay. Radiation is recommended to surgery, okay, and it is combined with chemotherapy. هلا بالsmall cell lung cancer we have 2 approved platinum doublets اللي هم EP etoposide with cisplatin and IP irinotecan with cisplatin. هلا according to NCCN guidelines between these two EP is the standard. يعني إذا إجا مريض limited disease أو حتى extensive small cell lung cancer, the chemotherapy of choice is EP, etoposide platinol أو etoposide cisplatin. Okay. هلا ال IP could be an alternative to EP. Okay. يعني ال IP treatment is not usually the first option. However, is an EP not available or patient did not tolerate etoposide, we can move or we can try IP. Okay. فبالتالي هون بالlimited disease احنا بنعطي radiation plus chemotherapy to the patient. هلا if the patient is stabilized, we recommend or we offer something we call it percutaneous cranial irradiation to the brain. Okay. Why we recommend that in the patient who respond to therapy, who have a stable disease after chemoradiotherapy? Because brain involvement is very common in recurrent or relapsed disease. فبالتالي احنا لما بنعطي هدول المرضى brain irradiation, we improve the chances to survive and we decrease the chances to relapse with brain involvement. لأنه إذا بصير relapse disease with CNS involvement and brain involvement, it's usually really aggressive and something really bad. فبالتالي المرضى على limited disease who respond to chemoradiotherapy, they are usually recommended to have or they are offered the PCI percutaneous cranial irradiation. هلا إذا المريض إجا extensive disease and most patients fall in this group, okay, again we go to chemotherapy. EP is preferred. Okay. يعني بهذا الستيج يعني concurrent radiotherapy is not usually recommended. يعني ممكن كتير إنه we just rely on systemic chemotherapy, we don't recommend radiotherapy. فهو not routine. Okay, you might consider it for very selected cases, unlike limited disease in which radiation is recommended. Okay, with chemotherapy. But extensive disease, it's mostly chemotherapy, EP regimen. Okay, first line. Routinely يعني radiotherapy عم نحكي هون عن يعني radiation of chest lung is not routinely recommended. Okay. طيب ال small cell lung cancer طبعا هو يعني as a percentage of lung cancers it's not big. يعني ممكن 10-15% of patients with lung cancer they have small cell lung cancer, fortunately, because this is really aggressive. Okay. لكن هدول المرضى اللي عندهم small cell lung cancer, okay, relapses, recurrence is common. Okay. فبالتالي how should we manage a recurrent or relapsed case? Based on time to relapse. يعني إمتى بيرجع المريض صاير معه relapse? This is really important. هلا كل ما كان time to relapse shorter, okay, it means that the disease did not respond from the very beginning to treatment. نعتبره refractory. Okay. الcut point أو value that we decide about it هي time يعني free time, disease free time or time between treatment induction and relapse كانت less than 90 days أو 3 أشهر, 3 months. So if the time to relapse was less than 3 months, احنا بنعتبر إنه this is a case يعني we consider it refractory, not responding, وبالتالي there is no need to repeat chemotherapy again. هدول المرضى عادة هم supportive care أو إذا في ongoing clinical trials we can recommend. Okay. فبهدول المرضى we don't go to second line chemotherapy because they are very unlikely to respond. يعني very short relapses, very early relapses. Okay. هلا في مرضى تانيين relapse time ممكن يكون prolonged. Okay, أطول. يعني مثلا we've seen cases in clinic, in hospital, مرضى بيجوا مثلا بعد 7 شهور 8 شهور relapses. بصراحة معظم المرضى يعني at least those I know about they do have relapses. Okay, يعني يعني أنا ما شفت مريض، ما بعرف maybe they do definitely exist، لكن غالبية المرضى they come with a relapsed disease اللي عنده small cell lung cancer. It's the time that might differ. يعني أكثر مريض شفته طول بالريلابس تايم كان يمكن around 1 year and he came again, he relapsed. ف relapse is really common in small cell lung cancer. فإذا كان الريلابس time above 3 months رجع المريض with the disease more than 3 months, okay, here we can try second line chemotherapy, okay, we can try it. The only approved FDA approved drug to treat second line relapsed small cell lung cancer هو topotecan, okay. الtopotecan belongs to what family؟ حدا بيعرف؟ topotecan شو الكلاس تبعه؟ same class with what؟ Yes عبد الرحمن.
زي irinotecan اللي هم camptothecin
Yes.
زي topoisomerase inhibitors.
Yes, very good. Okay. فهو belongs to the same family of irinotecan فهم topoisomerase inhibitors. Okay. فthe only approved يعني رح تقروا بكتابكم second line treatment for relapsed cases in small cell lung cancer في كتير أدوية chemotherapy drugs، لكن the approved one, the only approved FDA approved هو topotecan. Can be given parenterally or orally، ما في فرق بينهم. Okay. يعني if you treat with oral treatment you get the same outcomes as IV. Okay. فال IV ما له advantage بال second line management of small cell lung cancer recurrent or relapsed disease. Okay. فهدول المرضى we can try. We don't expect the response to be great but we can try. Okay. فبالتالي في عندنا second line treatment ل small cell lung cancer بال prolonged relapses. Okay. It's not mentioned in your book بس في يعني many ongoing trials about trying also immune checkpoint inhibitors in small cell lung cancer. I think some drugs are already approved. Okay. لكن it's not mentioned in your book. ف يعني expected إنه صار expansion a little bit to how to treat relapsed small cell lung cancer. لكن in your book just you need to know that topotecan هو ال FDA approved drug لل prolonged relapses. What does that mean؟ إذا بيجي المريض relapsed within 30 days أو 2 months we do not try topotecan. Okay. يعني at that time interval second line chemotherapy is not recommended. Okay. لا. Again if we treat okay patients we usually reassess. يعني إحنا حكينا on average we give the platinum doublet 4 to 6 cycles. Okay. عادة reassessment we always do reassessment. Okay. فعادة after the first 2 cycles of the platinum doublet or 3 cycles يعني midway تقريبا we reassess the patient. So as long as we have stable disease or we have some regression or we have good response we continue the treatment. إذا ما كان في عندنا good response maybe this indicates failure and so we have to discontinue and go to another treatment. وإحنا حكينا شو ال options available لل first line and second line treatments بالmanagement of advanced disease أو بالmanagement of the small cell lung cancer. Okay. فالرياسسمنت يعني مطلوب ودائما we do it. Okay. بمرضى الكانسر in general. Sometimes it's the time when to reassess. Okay. يعني إمتى we can decide that we can assess there is a response or not. The time interval this is maybe variable but we always need to reassess meanwhile. يعني ما بقدر أنا أعطي كل السايكلز أعمل assessment بالأخير. I have to know how the patient is responding after a few cycles to decide if we have to complete go with it or switch to another therapy. طبعا هذا assessment for efficacy or treatment efficacy effect. في كمان all the time في assessment لل side effects. Okay. يعني we always monitor adverse effects. يعني لما حتروحوا على المستشفى وتتدربوا دائما مرضى الأونكولوجي يعني قبل any new cycle بنعمل للمريض full check-up. Okay. We do CBC, we do cardiac function if necessary, liver function, kidney, electrolytes. يعني completely ونعمل complete checkup to make sure that the patient can safely go to the next cycle. Okay. إذا في أي issues that will يعني necessitate to delay or postpone a cycle, or toxicity cannot be tolerated that will necessitate that we drop drugs from protocols or switch protocols, we have always to consider it. فبالتالي قبل كل administration in the new cycle we have to completely check up the patient، نعمل له full check up. Okay. إذا في أي مشكلة we either hold the cycle، أو إذا في big issues with the treatment, severe toxicities, we can sometimes stop or switch. Okay. فهذا الروتين إحنا بنعمله when we treat patients with cancer disease. طيب هيك خلصنا lung cancer. Okay. We will move now to the final topic in solid cancers. Sorry, that's it. What's this? محاضرة تانية. Okay, 1 minute. Okay. شايفين سلايدات البروستيت؟
Yes, دكتور.
Okay, تمام. طيب. طيب this is the last solid cancer in the syllabus. Okay. طبعا the solid cancers they are a lot. يعني إحنا ما عندنا وقت to cover all of them. Solid cancers can happen to the GI يعني gastric carcinoma, esophageal, can happen to the uterus, endometrial carcinoma, ovarian carcinoma, sarcoma, cancer of the bone. Okay. يعني we have many يعني solid cancers. Brain cancers really common in pediatrics. يعني solid cancers can happen almost in every body organ with exceptions. يعني ممكن مثلا cardiac cancers are very rare. Okay. اليوم رح نحكي عن prostate cancer. Okay. يعني in almost all body organs, liver, hepatocellular carcinoma, it happens. Okay. Bone cancer, it happens. Connective tissue disease, it happens. فيعني solid cancer is a big topic. Okay. احنا ما حكينا everything. احنا حكينا most common, most important. في كمان skin cancer. That's another problem and so on. Okay. فاحنا اليوم رح نحكي about prostate cancer, which is the last solid cancer in the course. prostate cancer is a male disease. يعني احنا بنعتبر breast cancer is a woman disease. Okay. لأنه it's highly predominant in the women. Well, prostate cancer is definitely a male disease, a man disease. Okay. prostate gland normally يعني شو normal physiology, biology, why prostate gland is important for the male system. شو بتعمل prostate gland؟ النورمال physiology تبعها شو؟ عبد الرحمن, yes?
It secretes fluid that supports the sperms, and it also presses the urethra to help to pass the urine.
Yes, good. فإذا prostate gland is really important to the male genitourinary function, right? هلا it's very important for spermatogenesis مثل ما حكى زميلكم. يعني spermatogenesis normal, I would say, production activity, okay, is really dependent on prostate gland. Okay. كمان هي بتيجي just below. يعني إذا إحنا بنطلع على الاناتومي this is the seminal vesicles here. Okay. And this is the prostate gland. طبعا هي tri-lobe. يعني في 3 lobes. It's a gland that's composed of 3 big lobes. وطبعا في عنا above it على طول بيجي urinary bladder. This is the bladder. Okay. This is the rectum here. Okay. رح نحكي عن digital rectal examination. وفي عنا the ureter. Okay, that's going through it. فإحنا لما بنحكي about prostate gland هي very important to the male genitourinary function, important for sexual activity as well. If we remove the prostate gland, one very important side effect of prostatectomy, if we remove prostate gland, one very important side effect شو رح يصير؟ بما إنها important to the genitourinary system. بصير عندنا drop in what؟ نادين؟
ممكن يصير excessive sterility.
Yes. وشو كمان بيصير عندنا؟ يعني هو احنا بنقول له شو السكشوال درايف شو بنقول له؟ decreased libido. Did you hear of this word before? Libido? Okay. It is very much expected that if we remove prostate gland because of cancer of the gland, okay, and we have to do prostatectomy, for example, or prostatectomy is an option, then drop in sexual drive, libido, and spermatogenesis impaired, and so on. فهي إلها يعني several complications, especially if we talk of relatively younger patients. Okay, فبالتالي prostate cancer is usually a cancerous enlargement of the prostate gland because the prostate gland might enlarge in a benign way. يعني في عنا condition we call it benign prostatic hyperplasia. هاي الكونديشن ايش بصير فيها؟ Have you heard about it? Benign prostatic hyperplasia. What happens here? بيصير عنا enlargement of the prostate gland. Yes, Nadine?
دكتورة ممكن يصير as a result of urination.
Yes, as a result of the enlargement of the prostate gland رح يصير عنا urinary symptoms, right? رح يصير في urgency, frequency, رح يصير incontinence. وهاي symptoms, it can also happen if the enlargement is because of carcinoma. يعني واحدة من ال issues when we diagnose prostate cancer, if we don't do biopsy to confirm if this is a carcinous enlargement or not, it might be misdiagnosed as a benign prostatic hyperplasia. Okay, فبالتالي urinary symptoms, okay, complications will happen whether the enlargement is because of cancer in the prostate gland or just benign, non-cancerous. The gland is hyperproliferating, but this is not neoplastic. Okay. Benign prostatic hyperplasia means it is not transformed. It's not a cancerous disease. Okay, we treat benign prostatic hyperplasia completely different from the way we treat with prostate cancer. Okay, فهم الاثنين involve or associate with enlargement, urinary symptoms, but the management is highly variable. Okay, فإحنا هون رح نحكي about prostate cancer. إذا إحنا when we talk about the anatomy we talked about it, okay. بالmale patient حكينا إنها بتيجي the seminal vesicle secretes sperms, okay, through the prostate gland, and you know the prostate gland will secrete like a vehicle, other secretions requested, needed for spermatogenesis. فبالتالي هي very important for the reproductive activity. وحكينا إنه if enlarged, it start to cause urinary symptoms because it will start to push up the bladder, فالcapacity هون بتقل. كمان it start to block or يعني shut down the urethra. بالتالي بصير المريض عنده يعني urgency. If they go to toilet they cannot do complete voiding. يعني ما بيكون voiding complete. Okay, they start to have complications, issues. Okay, enlargement is bad. However, it's serious when it is a cancerous disease, prostate cancer. Okay, حدا بيعرف الnormal size of prostate؟ يعني نحكي adult patient. Average size of the prostate بالadult حدا بيعرف كم جرام مثلا؟ No idea. طيب خلينا نحكي هلا عن الهيستولوجي. اوكي هلا البروستاتيك gland, it contains normally epithelium cells, okay, and surrounded by again stromal cells. Epithelium in the prostatic gland is usually sensitive to the male reproductive hormone, which is the androgens. يعني بنلاقي normally بالوضع الطبيعي that in the epithelium of the prostatic gland, androgen receptors are expressed. But the growth and development, enlargement of the prostatic gland is dependent normally on testosterone or on androgens as a part of the male genitourinary system. Okay, فلما بيصير عندنا neoplastic transformation due to any reason, يعني رح نحكي في عندنا كتير factors, منها مثلا genetic factors, منها environmental factors, that the normal prostate epithelium transform becomes cancerous, neoplastic. Okay, when they transform to the cancerous neoplastic prostate cancer cells, the majority of prostate cancer retain androgen receptor expression. They are androgen receptor sensitive. They are androgen hormone dependent. بمعنى يعني 80% من prostate cancers normally they do express androgen receptor and they are sensitive to the hormone. They are sensitive to testosterone and dihydrotestosterone. فبالتالي خلينا نقول إنه majority 80% of prostate cancer are androgen dependent or hormone dependent. Okay, what hormone? اللي هو testosterone. Okay, هلا in small amount number of cases, يعني نقول maybe 15% of cases, 20%, the transformed cancer cell, okay, when the normal epitheliums transform, they lose androgen receptor expression, and so by definition we call these androgen independent tumors. Their growth is not dependent on the hormone. Okay, هلا a third scenario إنه many patients at presentation when they are diagnosed with prostate cancer, they start or they have at the time of diagnosis they have a hormone dependent disease or androgen dependent disease, but they can transform into hormone independent or androgen independent disease. So this scenario is also common. It happens. Okay. فمن البداية it could be hormone independent, but this is a small proportion. But the most of patients who are hormone dependent, however, they can transform. The disease might become resistant to the hormone or independent on the hormone. فبيصير after some time بيصير hormone independent. Okay. هلا as I said يعني إحنا prostate gland في إلها exocrine function. It secretes molecules, secretes things. Okay. فإحنا في عنا normal function to these epithelial cells. Okay. So they have certain morphology, structure, hierarchy, and function. When these become malignant or cancerous or neoplastic cells, we lose their function. Okay, we lose the normal function of these cells, and they start to grow out of control. They start to proliferate out of control. So the gland start to push. Okay, يعني راح يصير عندي هون pushing to the surrounding organs. Okay, فبالتالي it will cause disturbances in the surrounding functions. والcells itself will acquire abnormal characters or traits. They start to invade and migrate. يعني instead of being supportive, non-migratory, non-invasive normally, no, they start not only to grow out of control, but also they start to acquire some abnormal phenotype, okay, or behavior خلينا نقول. So they can invade the surrounding tissues. They can in many cases يعني they can invade to the pelvic bone. احنا هذا بنعتبره actually a very advanced disease. They can invade to the seminal vesicle, they can invert to the surrounding tissue. فبالتالي they become also abnormal in terms of behavior. ف prostate cancer is an important condition to be treated. هلا بشكل عام خلينا نقول انه البروستيت كانسر هو بنعتبره احنا some kind of يعني not very aggressive carcinoma. بيعتبروها بالمجمل more indolent compared to other cancers. Okay, يعني compared to maybe colon cancer, compared maybe to breast. يعني they are not very highly growing and they are not very aggressive in general, okay, compared to the other cancers. They are more indolent, okay. لكن within the carcinoma itself, يعني المرضى اللي بيجوا with prostate cancer, some patients they have very aggressive carcinoma and some patients will have maybe very slowly proliferating carcinoma, mostly differentiated. فرح نحكي يعني ال type of cancer cell is very important. The grading تبعها كتير مهم because it directly impacts the therapy that we can go for. Okay. فبالتالي ال prostate cancers once they are diagnosed, we have to consider options whether we can watch the patient, wait, or we have to proceed directly with treatment. The treatment highly dependent whether we have to start with an androgen-dependent cancer or hormone-sensitive tumors or androgen or hormone-independent cancers. Okay. But if we talk about prostate, we talk a little bit about androgens, which are the main sex hormone in the male subject. Normally, I would say like 95% of androgen in circulation comes from the gonads, comes from the testicular tissue, okay? فبالتالي ال circulating androgen, the main source هو the male gonad or the testicular tissue. Very small percentage comes from adrenal glands or other tissues, okay? طيب, if we say that 80% of the tumors هم hormone dependent, okay, to start with. Do you think if we deprive androgens in circulation, this would be helpful to treat those patients? يعني in your opinion, what is the most important model or modality or therapeutic consideration if we want to treat androgen dependent prostate tumors? شو أهم شيء إحنا نعمله لهدول المرضى؟ Any idea? Do you recall لما حكينا عن hormone dependent breast cancer? What was the goal? This is a tumor depends on a particular hormone. What should we do to stop the tumor growth? Yes, Rania?
دكتورة ممكن يكون في androgen receptor inhibitor.
Yes, excellent. يعني شو ال ultimate goal يعني? This is one group of the drugs. Yes, good. يعني إحنا شو هدفنا? To do what? To deprive, نوقف الهرمون. Yes. يعني إحنا هدفنا to stop this signaling, this activity by the hormone because the growth is dependent on it. فبالتالي لما إحنا بنحكي about treating androgen dependent prostate cancer, the most important group هي الهرمونال therapy أو الهرمونال treatments, with the goal is to stop the effect of the hormone to stop the growth of the cancer. Why? Because the cancer is hormone dependent. Okay? فبالتالي we know that most androgens come from the gonads or the testicular tissue. What could be one option of treating patients here? إذا معظم circulating hormone بيجي من testicular tissue. What can we do? احنا حكينا بالبريست كانسر. Do you remember لما قلنا we can do oophorectomy? Do you remember for hormone dependent breast cancer to cause a drop in circulating estradiol and deprive the tumor from the estrogen? So what can we do here to induce castration? Estrogen levels go very down in circulation. Yes, Sanar.
ممكن تستكتمي علشان إنه نثبت الهرمونات.
Yes, good. So we can also remove the gonads here, right? We can remove the testicular tissue. بنقول له orchectomy. Okay? Removal of the testicular tissue. فبالتالي بما إنه الهرمون is really important here and most cases 80%. Okay? Then blockade of androgens, particularly testosterone and dihydrotestosterone, is usually the goal of therapy. How we can reach this, how we can deprive or decrease the level of androgen in circulation, or how can we stop the effect of androgens on the prostate tissue, we have different classes of drugs. Okay? فإذا the goal of hormonal manipulation or treatment, and this is really important, is to reduce the levels of circulating androgens. When we reduce the level of circulating androgens, we have a particular level that we have to hit. بنقول له castrate level, castration, okay? Then we can highly stop, okay, tumor growth, and actually we can induce regression. If the hormone that is used to maintain growth survival is not available, we can induce tumor regression. Okay, فهاي يعني الموديل او هاي الجروب كتير مهمة بالبروستات cancer because most cases already have androgen dependent disease. طيب هلا generally prostate cancer is a disease of old age. يعني خلينا نقول most cases we expect to see in 60s, 70s. So it's a disease of the elderly. Definitely advancing in age increase the risk. يعني كل ما العمر زاد the risk of prostate cancer is increased. Okay. الامريكان statistics يعني خلينا نقول اليو اس statistics البروستيت هو most common but it's not the most lethal or it's not the most يعني the one that causes to the most fatality. Okay. actually lung is the most lethal. Okay. فهو يعتبر very common carcinoma وعادة مثل ما حكينا بالelderly. Okay. prostate cancer generally speaking هو very unlikely in the young patient. Okay. يعني احتمالية ألاقي أنا مريض عنده prostate cancer بعمر 30 20 very very unlikely. Okay. فهو من الكانسرز اللي مرتبطة كتير بالaging. Okay. فبالتالي aging is a very important risk factor. Family history is very important. يعني مثلا having a father with prostate cancer increase the risk of the son. مثلا من الطرف العم أو الخال second degree كمان بيزيد الريسك. ما في عنا we don't know a single gene that is known to correlate with the risk. يعني مثلا احنا حكينا بالبريست حكينا عن البراكا genes very يعني well known. بالبروستات ما عندنا specific genes إنه إذا فيهم mutation the risk is highly increased. ما عندنا so far. لكن في عندنا we know that certain genes like P53 retinoblastoma هاي كتير مهمة. يعني P53 controls cell cycle, retinoblastoma controls cell cycle. الandrogen receptor أو الEC adherent very important in prostate. We have some genes that are known if they are mutated or if we lose the function like P53 for example, it might increase the risk of prostate cancer. هلا في environmental factors أهمها exposure to cadmium. Okay. يعني cadmium exposure بالذات لقيوا إنه associated with increased risk of prostate cancer. lifestyle كمان is important. Western lifestyle يعني خلينا نقول high fat diet, high salt diet, obesity, lack of physical activity, they can all contribute to the risk of prostate cancer. بالethnicities كمان لقيوا إنه في differences، يعني مثلا لقيوا إنه the African Americans أو Black people, the incidence or the risk of prostate cancer is much higher than Asians, for example. ولما يعني they did further investigations لقيوا إنه actually these two are different in 5-alpha reductase enzyme levels and activity. رح نحكي عنه. Okay. فبالتالي كمان ethnicity طبعا نحكي US population is important. Benign prostatic hyperplasia, as I said, okay, benign prostatic hyperplasia itself is not a risk factor. It does not itself increase the risk. بمعنى الادلت او الالدرلي اللي بيجي عنده benign prostatic hyperplasia هذا لا يعني انه his risk of prostate cancer is increased. Okay, فهي مش risk factor بالمعنى, but it complicates presentation and the treatment. يعني it makes the case complicated. اوكي, لكن احنا ما بنقدر نعتبر انه اي مريض عنده benign enlargement of prostate it means that patient is at risk for malignancy or carcinoma of the prostate. اوكي, هلا smoking and alcohol consumption يعني ما لقوا انها strongly associated with the risk of prostate cancer. اوكي, يعني مش من leading يعني strong risk factors. Okay, but definitely they are bad. Okay, يعني smoking increases oxidative damage, attack on membranes, ممكن مليان carcinogens. alcohol same idea. Okay, they might not be directly associated with a risk, but they are definitely bad. Okay, to any kind of carcinoma, not only prostate. طيب, family history, as I said, important. Okay. patients اللي عندهم family history يعني مثلا average adult male with family history they are at increased risk and they have to screen earlier. رح نحكي عن screening. okay. حكينا ما في عنا very specific genes. okay. واحدة من ال يعني الفاميليال causes هو الفاميليال clustering of chromosome 1, بس ما عنا يعني very solid evidence about association of familial factors with prostate cancer. Male carriers of BRCA mutations can be at increased risk of prostate cancer, لكن يعني برضو مثل ما حكينا الريسك هون does not correlate with the BRCA mutations in causing أو مثلا predisposing to ovarian and breast cancer in the female subject. Okay. ف in general يعني ما في عنا clear familial or genetic cause. في عنا genetic factors that can increase the risk. Okay. بس ما في عنا strong evidence of a very strong correlation or association between one gene and the risk of prostate cancer so far. فالفاميلي history مهم, aging مهم, الethnicity طبعا يعني بالUS population كمان مهمة. هلا احنا حكينا انه الاندروجينز الاندروجينز هي جروب طبعا of hormones. التستوستيرون okay is a very important androgen. Usually it is released by the gonads, released by maybe adrenal glands, some other tissues, and it is converted, testosterone itself is converted to dihydrotestosterone. Okay, dihydrotestosterone is more potent, okay, than testosterone. It binds the androgen receptor at higher affinity. Okay, يعني if we compare testosterone and dihydrotestosterone, actually dihydrotestosterone is a more important hormone for the growth and activity of the genitourinary system in the male. This conversion here is conducted by enzymes, group of enzymes, we call them 5-alpha reductases. Okay, we have 2 isoforms. So they will convert testosterone to the more potent androgen, اللي هو dihydrotestosterone. Okay. هلا بما إنه يعني the majority of prostate cancer cases هم androgen dependent, okay, in nature or hormone dependent, there was steps toward chemoprevention. يعني how can we reduce the risk or prevent prostate cancer. okay. فالفكرة كانت إنه if we use 5-alpha reductase inhibitors, we stop the conversion of testosterone to dihydrotestosterone, the very potent androgen, and so the hormone will not be available at high levels, and so we decrease the transformation of the normal prostate epithelium because of the effect of this hormone. فهذا بنقول له chemo prevention. We use drugs here. There has been 2 drugs introduced as 5-alpha reductase inhibitors اللي هم finasteride and dutasteride. They are both 5-alpha reductase inhibitors. However, finasteride هو selective type 2 inhibitor, while dutasteride inhibits both types 1 and 2 of the enzyme. Actually, types 1 and 2, both of them, has been associated with conversion of testosterone to dihydrotestosterone and prostate cancer. فبالتالي, if we inhibit these enzymes, it was believed that we can also decrease the risk of development of prostate cancer. However, يعني, when the follow-up studies was done, يعني تابعوا المرضى اللي هم كانوا على chemo prevention with dutasteride or finasteride long term for many years, يعني they found actually إنه it is right، يعني هو صحيح إنه the incidence or the number of the new cases of prostate cancer might decrease. However, patients who develop prostate cancer will have more aggressive forms. يعني خلينا نقول إنه 100 مريض okay at risk of prostate cancer will start chemo prevention with finasteride. Okay. و100 مريض تانيين follow up أو control ما عم ياخدوا chemo prevention. Okay. It's true إنه the number of cases اللي راح تصير على الجروب اللي بياخد الفينسترايد هي أقل. يعني خلينا نقول ممكن مثلا من جروب الكيمو بريفنشن 30 مريض يصير معهم prostate cancer مقارنة بالكنترول ممكن 50 أو 60 مريض يصير معهم breast cancer. فهو فعليا it reduces the incidence, that's right. لكن هدول 30 مريض اللي راح يصير معهم prostate cancer وهم بياخدوا chemo prevention, their tumors are aggressive and high grade. Unlike the typical presentation of prostate, which is known to be more indolent, more slowly growing tumors. Do we need to consider chemo prevention or not? Okay. To be honest, هذا الquestion لسه عليه debate. For now, they are not really recommended. إنه أنا أعطي 5-alpha reductase inhibitors to prevent prostate cancer. هلا في selected cases might be negotiated on a person by person. يعني يتفهم المريض كل الissues اللي ممكن تصير مع treatment. يعني صح هو إحنا عم نعطيه to prevent prostate cancer, but if it happened, it will be an aggressive tumor. Okay. The chances maybe to treat survival are reduced. فبالتالي it is a complex scenario صراحة. Still we don't have a clear approval from FDA that we can use these drugs for chemo prevention. Okay. فهم هذا الموضوع complicated. Other trials tried vitamin E مثلا. They tried also selenium. A big trial selenium and vitamin E trial to prevent prostate cancer was a very big trial actually, but unfortunately these treatments did not also improve or reduce or prevent prostate cancer. Did not show any really promising or positive outcomes. فحتى الفيتامين E والسيلينيوم في ناس بيعتبروهم فيتامين E هو vitamin supplement. It did not show a positive effect. In prevention of prostate cancer, it did not give a positive effect. فحتى هدول we do not recommend them for prevention. Okay? ما في evidence. To be honest, so far ما عندنا chemopreventive method ما في. Okay? Approved, I would say, with evidence. So far we don't have for prostate cancer. طيب هلا screening is important. Okay? We have 2 important screening methods for prostate cancer: digital rectal examination and prostate-specific antigen. Usually we do these 2 together. اوكي. يعني ال DRE لوحده لا يكفي. ال PSA أخذته I think يمكن بال clinical chemistry اللي هو عبارة عن biomarker molecule secreted by the prostate cancer cells. فهذا we measure it in circulation. فهذا عبارة عن blood biomarker. هذا عبارة عن exam رح نحكي عنه. يعني هم الاثنين لهم drawbacks، لهم مشاكل. So usually we have to do them together. Okay, in case we are screening. هلا بالdigital rectal examination, what's going on? The physician, okay, wearing a glove, they insert the finger to touch, to feel the gland. يعني they can physically examine the gland. ببين مع الفيزيشن إذا كانت enlarged، إذا كانت hard tough، إذا كان في مثلا abnormal lobules. يعني هذا الإكزام أوكي هو direct exam to the prostate. It can tell there are enlargement abnormalities. It can tell, but it will not tell me if these abnormalities are cancerous or not. But this is important because it will tell you if there are abnormalities going on. فهذا بنقول له digital rectal examination أو بنقول له DRE. DRE will tell you if there is a direct problem with prostate. It's a direct examination of prostate, but it's not very يعني I would say sensitive. Okay, it's not very sensitive. However إحنا بنعتبره safe with low cost. المشكلة هون إنه يعني في variability بين ال observers. شو يعني؟ يعني if physician A is doing the exam, they might report findings different from physician B or C doing the exam. ففي عنا variability. اوكي اللي هي بنقولها الobserver او يعني physician variability. يفضل if patients are doing the digital examination, rectal examination, they always do it with the same observers to minimize the يعني variability. اوكي فبيكون في baseline observation, and then you go again for another screening with the same physician. فبالتالي probability إنه في variability from one physician to the other, observer to the other, is minimized. Okay. فهو مثل ما حكينا it will tell if there is a problem directly with the prostate because we are checking prostate، لكن هو مش كتير إشي specific. ما رح يقول لي this is definitely prostate cancer. We need to do. If we have abnormalities, then we need to follow it. We need to do BSA, we need to do maybe biopsy depending on other findings. prostate specific antigen هذا عبارة عن blood marker أو نقول له biomarker. Okay. هلا it is expected that most patients with prostate carcinoma they will have elevated PSA. متوقع إنه كتير مرضى اللي معهم prostate cancer رح يكون elevated، لكن the PSA can be also elevated in other يعني in other issues. And some prostate cancer patients they don't have high أو يعني clearly elevated levels. Okay. فمش كل المرضى اللي رح يجوا معهم prostate cancer they have elevations. فهو يعني مش كتير specific. يعني أنا ما بقدر بالاعتماد على الvalue reading of PSA to directly decide whether I have prostate cancer or not, because as I said elevations can happen in other cases like benign prostatic hyperplasia مثلا ممكن تعمل elevations in the same range as prostate cancer. يعني ما أقدر أفرق بينهم just based on the readings. Okay. ممكن مثلا كتير مرضى يجوا عندهم prostate cancer I check PSA it is not really elevated. فبالتالي if it is elevated it might give you an idea, okay, along with prostate digital exam, rectal digital exam. لكن مشكلته هذا إنه مش specific، ومثل ما حكينا false positivity عالية لأنه ممكن يكون عالي not because of prostate cancer because of other condition. بس إذا كان عالي okay with digital rectal exam abnormality أو المريض جاي عنده يعني urinary complications يعني أكتر signs بتيجي مع البروستيت كانسر إنه المريض start to develop يعني genitourinary symptoms. أوكي، فبهاي الحالة we have to do further check. يعني لازم نعمل مثلا radiation. We have to see the size of the prostate. Okay, وإذا اضطرينا بنعمل biopsy if we have suspect إنه this is cancerous. Okay, فالdiagnosis لازم يكون definitive. يعني لازم أكون 100% sure this is cancer or not, because if we treat carcinoma as benign condition or we treat benign condition as carcinoma, that's a big problem. Okay, فبالتالي we do the digital rectal examination, PSA, ultrasound, radiologic examination, and finally, if we could not distinguish or tell if this is a benign condition or carcinoma, we have to do biopsy. فبشكل عام السكرينينج ابروتش المرضى اللي هم average risk، يعني مثلا they don't have a family history of the disease, not out in يعني مش ethnicity at high risk مثلا، ما عندهم environmental factors or lifestyle factors. خلينا نقول هدول عادة ال PSA وال DRE they start ال annual screening at age 50. يفضل we recommend إنه يكون عندهم baseline at age 40. Okay, يعني we take a baseline and after 10 years للaverage risk patient هدول we start to do these screenings annually every year. Okay, at age 50. اللي بيكونوا high risk مثلا في first degree family history أو مثلا high ethnicity with high risk، يعني في عنا risk factor، هدول يفضل إنه إحنا نعملهم annual examination with digital rectal exam and PSA starting age 40 or 45. ف يعني they screen earlier and on annual basis. Okay, compared to the average risk individual. Okay. طيب هلا if we have a case مريض إجا على الكلينيك digital rectal exam was مثلا في abnormal findings, PSA was slightly elevated أو elevated, في عنده symptoms, we want to go to the biopsy. Okay, فالbiopsy here simply this is a transducer, this is a needle. Okay, اللي هي رح تاخذ السامبل يعني under يعني careful monitoring with ultrasound. The physician will start to take samples. هاي بنقولها الكور أو السامبل. لازم تكون السامبل from the 3 lobes وتكون من كل لوب أكثر من سامبل. يعني ما بناخذ one sample from a single lobe. أوكي، فإحنا لما بنعمل biopsy الفيزيشن طبعا will turn the lobes ورح ياخذ من كل لوب أكثر من sample. يعني تقريبا بياخذوا ممكن 3-4 samples from different sites in the same lobe and from different lobes. أوكي، هلا هاي السامبل tissue sample بتروح على الباثولوجي department بالمستشفى. أوكي، the pathologist will look at the tissue. They will decide if it is prostate carcinoma or not. فبالتالي يعني أول شيء أنا بستفيد منه بالsampling I can confirm or rule out cancer. Okay, فبالتالي أول شيء إحنا بنعمله إنه is this tissue belong to cancer or benign prostate tissue. If it is cancerous, يعني if we confirm this is a cancer, we have to give a score that correlate with the aggressiveness of the cancer. فهذا كمان بينعمل على هاي التيشو samples. هذا السكور اسمه جليسن سكور، وهذا السكور كتير مهم وكتير مهم مش بس للبروجنوسيس، كتير مهم كمان للتريتمنت. اوكي، فالجليسن سكور will give or assess the degree of differentiation and proliferation of these cancer cells. فعندنا 3 ranges للجليسن سكور. اللو رينج يعني مثلا إذا حكيت لكم أنا prostate cancer Gleason score 3 2 4. أوكي، فهذا اللو رينج 2 to 4 طبعا هو it will never take 0، فاللو رينج اللي هو 2 to 4 وما رح ياخذ واحد لأنه إحنا بنجمع هاي السكورات from 2 readings. Anyway يعني السكور ببلش from 2. 2 to 4 بنعتبره low score, which means لما أنا أقول low score Gleason, it means that the tumor cells, the prostate carcinoma cells, they are not highly proliferating. They grow slowly, okay, but they are still well differentiated. فبالتالي لما بتكون الكانسر cells highly differentiated, they are slowly proliferating, and the prognosis here is considered good, which means this is not a very aggressive carcinoma. This is not high-grade carcinoma. هذا المعنى. Okay. فإذا كان the Gleason score low, إحنا بنعتبر إنه this is an indolent tumor. The cancer cells grow very slow, okay, very slow. It's indolent, and we consider this patient could be a candidate to the watch and wait, okay. وبالتالي يعني بنعتبر إنه the prognosis all in all is good. طيب الهاي سكور على الجليسن هو 7 to 10, okay? It means that the cells proliferate very fast, they are highly proliferating, and they are very poorly differentiating. فهذا high grade tumor, okay? يعني هاي cells very aggressive. وبالتالي احنا بنعتبر هذا المريض اللي عنده الجليسن score above 7 نعتبره in terms of prognosis is poor, okay? It's not something good. ال 7 to 10, usually these are aggressive tumors and we have to treat directly, we don't wait, because the tumor grow very fast, divide, proliferate very fast, okay? فهون ما عندنا watchful waiting بالهاي سكور Gleason, okay? هلا الانترميديت او السكورز between 5 or 6, 5 to 6 هدول احنا بنعتبرهم in the middle, okay? It is not really يعني good prognosis, but it's not very poor. The cells are not very or highly proliferating, but they are not also يعني very well differentiating. فهذا احنا بنعتبره something in the middle, okay? اللي هو 5 to 6. فالجليسن سكور كتير مهم ولازم تحفظوه لأغراض التريتمنت, because we will select treatment approach based on the Gleason score, okay? حدا عنده سؤال بالجليسن score before we move to staging؟ في أي سؤال فاهمين؟ هو نفس الفكرة تبعت الجريد علاقته بالproliferation والdifferentiation. We've talked about this many times before, okay? بس بهاي الحالة it is well structured. We have scores that correlate with outcomes and prognosis, okay? طيب إذا ما في سؤال, let me go to the staging. طيب هلا ال staging بالprostate cancer is again depending on the TNM stage. فإحنا في عنا tumor size, في lymph node involvement, وفي metastasis, okay? The definition of metastasis here is a little different from what we talked about in other solid cancers رح نحكي عنه. فال TNM staging, okay, يكافئه بالأستراليان system إيش بنقول له the A to D staging. يعني كل TNM stage, okay, تكافئها letter أو تكافئها stage based on the Australian staging system اللي هو A to D, okay. مثلا لما إحنا بنحكي stage 1 prostate cancer, this is the prostate cancer, this is the pelvic bone, وهاي السيمينال فيزيكل كتير مهمين هدول للستaging, okay. ففي عنا this is the seminal vesicle, this is prostate, this is the pelvic bone, وفي عنا هون lymph nodes, okay, regional أو local lymph nodes, okay. فلما إحنا بنحكي stage 1 based on TNM وهو يكافئ stage A على الأستراليان system, we are talking about small tumors found in one lobe, okay. يعني هون أنا عندي very confocal tumor, فأنا بحكي عن small tumors, okay, usually limited to a single lobe. هذا إحنا بنعتبره stage 1 disease, okay, أو stage A disease. طيب stage 2 disease اللي هو هون يكافئ stage B, اوكي طبعا كل ستيج في لها سب كلاسز مثل ما كنا نحكي بالستيج 1A 1B هون نفس الشيء B1 B2 and so on. فبستيج 2 disease excuse me the tumor can be found in more than one lobe يعني ممكن يكون 2 or 3 lobes لكن stage B disease it did not reach the seminal vesicle, it did not reach the lymph node or the pelvic bone يعني it's still confined بعده موجود within the prostate but now it's spread يعني موجود بأكثر من لوب اوكي فهذا يكافئ stage B اوكي هلا stage C disease عادة بstage C disease the cancer cells start to go out okay of the prostate they will reach most probably the seminal vesicle but still they did not reach the lymph node or the pelvic bone okay فإحنا هذا بنعتبره stage D أو اللي هو advanced disease stage 3 يعني locally advanced disease فهون في عندي بالليمف بال seminal vesicle I see we detect the cancer cells prostate cancer cells لهون يعني stage A B and C okay أو stage 1 2 or 3 هو بصراحة يعني we better refer to A B C لأنه بالكتاب راجع لهم أوكي فخلينا نقول stages A B and C أوكي it is not metastatic يعني the disease is not metastatic أوكي so far هلا لما بنروح على stage D عفوا أوكي when we go to stage D اللي يكافئها إحنا بالTNM stage 4 أوكي here Now this is metastatic prostate cancer. Okay. فباي definition امتى انا بعتبر البروستات كارسينوما metastatic؟ اذا وصلت على الليمف نودز اوكي الريجنال ليمف نودز او البلفيك بون او distant organ اوكي او distant organ فبالتالي البروستات cancer if it reached the lymph nodes This is metastatic disease بتعامل معه كأنه distant metastasis okay إذا وصلت هون على pelvic bone the very close bone here كمان بعتبره metastatic disease حتى لو ما لقيته ب other organ يعني حتى لو ما لقيت carcinoma بالvisceral organ بالليفر بالبلادر بالsoft tissue حتى لو ما لقيته مجرد إنه it spread to the pelvic bone هون والlymph nodes هذا D stage D أو هذا عبارة عن metastatic disease okay طبعا التريتمنت variable okay prostatectomy can be considered as long as prostatectomy means we resect we remove the entire prostate okay prostatectomy prostatectomy can be considered unless we have metastatic disease if we have metastatic disease stage D Prostatectomy is not an option. There is no need to remove the prostate because the tumor spread outside the gland. Okay? لكن لغاية stage 2 مثلا stage 3 we can still أو stage B and C we can still prostatectomy is still an option. Okay? But not in stage D. Okay? هلا الميتاستاتيك prostate cancer يعني where we can find what are the distant organs احنا حكينا انه regional او pelvic lymph nodes pelvic bone very common sites of metastasis however it can also يعني we can also see very distant metastasis ممكن يوصل على البasilar organs ممكن اشوفه باللung بالliver other bone okay and soft tissue ممكن أشوفه حتى بالبرين in really some cases we can see prostatic cancer يعني metastasis to the brain فبالتالي الميتاستاتيك disease ممكن يكون region involvement أو يكون distant فهذا إحنا بنعتبره بالحالتين metastatic disease and we have to treat as a stage D disease طيب هلا البروجنوسيس بالبروستات cancer when we think that the patient has good prognosis or not إذا كان عندي low Gleason scores which mean low grades هذا بنعتبره good prognosis. Smaller tumors limited to one lobe بنعتبره كمان good prognosis. التيومر cells كل ما كانوا well differentiated كل ما كان البروجنوسيس أفضل. أوكي فبالتالي يعني بشكل عام we rely on the tumor factors. يعني كتير بيهمني التيومر factor لما أنا بحكي عن البروجنوسيس. أوكي يعني الage مثلا حكينا معظمهم هم بيجوا elderly فبالتالي أكثر أشياء بتحدد البروجنوسيس هي the tumor factor itself. شو طبيعة التيومر اللي إجا لما إحنا عملنا analysis وعملنا diagnosis للبيشنت. That's really important. أوكي فمثل ما حكينا إذا أنا عم بحكي عن stage 1 أو stage A أكيد الكيور ريت كتير أعلى من إنه أنا عم بحكي عن stage D أو D2. D2 حتى يعني مش بس local يعني distant. أوكي ف by definition stage D اللي هي الميتاستاتيك phase سواء كان D1 or D2 هذا مش curable. We are not actually curing. اوكي يعني بمعظم حالات الميتاستاتيك tumors حكينا انه the cure rate is really low. اوكي فاحنا ممكن نعتبر stages A, B and C pardon ممكن نعتبر stages A, B and C potentially curable. طبعا the cure rate بيقل as we move from A to C. Okay stage D whether D1 or D2 this is not curable. We mostly treat to stabilize the disease, improve the quality of life. Okay طيب خلينا نوقف هون. Okay and the treatment we will proceed next time. اوكي طيب امتحان الفاينل تحدد اليوم بالسكيدجول رح يكون جون 6 إن شاء الله يعني يوم الأحد 6 جون. أوكي ف يعني I think إنه we still have time تقريبا عنا حوالي كمان أسبوعين بعد العيد إن شاء الله. أوكي فإحنا رح نخلص يعني I'll do my best إنه نخلص إن شاء الله prostate cancer and we will see يعني حنشوف بالنسبة للtime constraints if we can proceed with a solid organ transplant or not. Okay لكن إن شاء الله يعني definitely prostate cancer we will finish the topic لأنه كتير مهم بنشاف كتير بالكلينيك as a tumor. أوكي فمبدئيا المادة اللي ما تغطت بالميدترم هي الليمفوما و4 chapters بالsolid cancers فمبدئيا أوكي والفاينل رح يكون out of 50 points والتركيز على مادة الفاينل. أوكي يعني هو comprehensive فأكيد رح يكون في few questions من مادة المد few questions يعني مش كتار وعادة بيكونوا يعني إحنا إشي بنقول له carry on knowledge يعني something that you have to answer really without needing to revise the material. فهي التركيز رح يكون على مادة الفاينل إن شاء الله. If you plan to study in the coming vacation مادة الليمفوما والبريست والكولون is already uploaded. Within 2 days إن شاء الله أنا رح أحمل لكم كمان مادة اللنج. I think بتشابتر اللنج كانسر كمان إحنا بنطلب treatment part only مش كل chapter. ف I'll do my best maybe shortly to upload the material to you. إذا عندكم أي أسئلة let me know. Okay وبليز يعني تشيك كل طالب يشيك يعني علامة المد تبعته يعني يتأكد إنه ما عنده concerns لأنه على الأغلب إحنا رح نعتمد العلامات قريبا. أوكي فبليز if you have any concern بالعلامة أو concern بالأسئلة يعني أنا يعني ما في ولا طالب رجالي بخصوص مادة المد. إذا أي طالب عنده سؤال please feel free to email me. أوكي ف I am done for today. أوكي إن شاء الله كل عام وأنتم بخير. بعد العيد إحنا رح نكمل إن شاء الله prostate cancer. We will see how things will go بالنسبة لل solid organ transplantation. if you want to leave you can leave. أوكي إذا في حدا عنده سؤال I can take it. سنار تفضلي.
يس دكتورة، بدي أسأل عن
تفضل.
مادة المد. المفروض
Yes.
نكون يعني راجعين الجايد لاينز والأدوية صح؟ يعني مش إنه بناء على دراستنا للمد.
يعني شوفي، هي رح تكون، يعني أنا ما بقدر أقول لك كيف رح تكون الأسئلة، بس هي رح تكون very straightforward, carry on knowledge. You got my point؟ يعني هاي مادة أنتم امتحنتوا فيها، يعني هي رح تكون أسئلة، يعني المفروض لو أسألك هلأ السؤال أنت تجاوبي. فهمتي علي كيف؟ يعني هي إحنا بنقولها carry on، وعادة رح يكون يعني very few questions. إحنا عادة يعني بنجيب، لأنه أكيد يعني الرولز بالregulations بالجامعة لازم يكون الامتحان comprehensive. أوكي؟ لكن التركيز رح يكون اللود على مادة الفاينل، المادة اللي أنتم ما امتحنتوا فيها، هاي رح يكون عليها اللود. أوكي؟
تمام، شكرا.
أها، أهلين هلا. طيب